Well, welcome, ladies and gentlemen. Thank you all for attending. I'm sitting here instead of Dr. Goodman. Big shoes to fill, but I will try to fill them as well as I can. I'm pleased to introduce Dr. Sabine Hildebrandt, a colleague of mine, who's down from Harvard to visit just for the day. I'm going to give us a talk today on why medicine in Nazi Germany is still relevant today. This is based on some work she and a number of her colleagues did on the Lancet Commission on medicine, Nazism, and the Holocaust that was published just a while ago. You can certainly get copies of that. Sabine can forward on information, etc. It's a very useful and topical area that I think will be relevant for many of us. So with that, I'll let Sabine start, and we can certainly take questions afterwards.
Thank you so much for having me here. I'm truly pleased. And as I always say, I will speak to the chosen few. So thank you for having me. Truly a good opportunity. So what I'll do today is bring to you some of the main findings, the core findings from our Lancet Commission on medicine, Nazism, and Holocaust, and discuss the question why medicine in Nazi Germany is still relevant today. I will give you a brief overview, and then I hope we will have time for a discussion and many, many questions, as many as we possibly think of. And I will start with Dr. Hannah Hellmann. She was born in 1877 to a Jewish family in Bavaria. And she was one of the first women who went to a full university study in literature and philosophy. And she earned a doctorate, and then worked as a scholar and teacher of literature and philosophy at a seminar for social medicine in Frankfurt, in the middle of Germany. Unfortunately, in the 1920s and 30s, she started to display personality changes and had so-called visions. At the time, she was then able to communicate via art. She became nonverbal, but she was able to communicate her life with others through her art, and you see here one of her charcoal drawings, and in this case, actually a crayon drawing. In 1938, an anti-Semitic neighbor denounced her to the authorities, and she was forcibly committed to a psychiatric institution. Her sister was able to bring her into a private Jewish institution, but all of those were closed in 1939, and at the time, only one Jewish psychiatric hospital was left to care for these patients. That was in Western Germany, in the region of Koblenz. Then, in the summer of 1942, Dr. Hellmann, together with hundreds of other patients and staff, was then transported to the Ispica ghetto in occupied Poland, and was then transported on to the Sobibor extermination camp, where she and the others were immediately killed. The question is, what happened to Dr. Hellmann, and what happened as the story behind all of these killings? More than half of all German physicians willingly joined the Nazi Party between 1933 and 1945. They collaborated in the dismissal and persecution of their Jewish and politically dissident colleagues, eagerly filling the resultant vacancies. The victims were forced to flee or risk imprisonment and death. German health professionals also helped prepare sterilization legislation and performed these forced procedures at only 310 to 350,000 victims labeled as genetically inferior. And you see a documentation of these procedures. Wilhelm Werner himself became such a patient. He also was then later a victim of the so-called euthanasia patient murder program, which started during the war in Germany in the conquered territories, when doctors, nurses, and midwives murdered between 250 and 300,000 patients with various mental, cognitive, and other disabilities as so-called lives unworthy of living. Notably, few health professionals openly refused to collaborate in any of these activities, though those who did were rarely sanctioned. The transfer of staff, including health personnel and killing expertise from the euthanasia apparatus to the extermination camps of Operation Reinhardt, the extermination of Jews living in German-occupied Poland, contributed to the murder of 1.7 million Jews and an unknown number of Roma and Soviet prisoners of war. Tens of thousands of individuals were subjected to forced medical research, resulting in great suffering, maiming, and death. Some of the knowledge gained from this research has been used for many years later, even today. The image that you see here is of Maria Kosmelchuk, a Polish political prisoner in Ravensbrück, who together with her fellow prisoners actually documented here the effects of the experiments that Dr. Gebhardt and Herr Oberholzer had committed on them with sulfonamide experiments and false wounds. And that photo was taken secretly and courageously by a fellow prisoner, Germaine Tillion, in October 1944. It was important that these women here basically documented their own suffering. They defied their captors and risked their lives in order to document the medical atrocities. And these documents were used later in the Nuremberg medical trials. We have deliberately not chosen any of the other experimental photos that you often see in publications on the topic because they show the perpetrator's view of the victims. And we wanted to show here the victims' agency themselves. At the same time, when all of this happened, many persecuted physicians in concentration camps and ghettos under horrific conditions and faced with impossible moral choices sought to continue teaching and research and to care for their patients as best they could, doing their utmost to save lives. In the ghetto specifically, Jewish medical personnel's resistance against Nazi oppression manifested in the continued provision of medical services through what remained of community infrastructure established in the interwar years. Medical care providers here you see as a team working on a sick child in the ghetto in Wetzingen, occupied Poland. All of these experiments were only partly then brought to light to a wider world in the Nuremberg medical trial, 1946 to 47. Of the 23 defendants, 20 were physicians, the rest health administrators. Of the experiments investigated there were the high altitude, low temperature and drinking of seawater experiments at Dachau concentration camp, the typhus and infectious jaundice experiments at various camps, the sulfonamide, bone grafting, and cellulitis experiments in, for example, Ravensbrück, but also elsewhere, and the mustard gas experiments that were conducted on the forced laborers and prisoners at Natzweiler Strupphof concentration camp. Other medical crimes that also were on trial at the time were a collection of skulls of Jews for Straßburg that was never finished, and the so-called euthanasia program. What's important here is to note that there were many more perpetrators of medical crimes, not only a few monstrous psychopaths, as was also often said after the war. Rather, and this is really to have to be emphasized, most of German medicine became complicit in collaboration with the Nazi regime. There were also many more experiments of unspeakable cruelty with many more victims, close to 30,000 victims of nearly 200 medical experiments have by now been identified by medical historian Paul Weindling and his team. And from 1943 on, there were increasing numbers of Jewish victims among them. And most of the survivors suffered long-term health effects with little or no recognition of the crimes committed against them and no support and legal compensation. The men you see here in this photo are Frank and Otto Klein at one of the post-war meetings of the twins who survived the Auschwitz experiments by Josef Mengele. This photo shows Karl Brandt, Hitler's physician, listening to his verdict of capital punishment at the verdict day at the Nuremberg medical trial on 19th of August 1947. One outcome of this medical trial was a section of the verdict that was titled Permissible Medical Experiments. It had 10 points, and point 1 said that the voluntary consent of the human subject is absolutely essential for any medical experiment. This presented a milestone in the codification of the principles of bioethics and became later known as the Nuremberg Code. The principles of bioethics consent, beneficence, respect, and justice. However, the code was widely ignored until the 1960s when the new movement of bioethics started here in the United States. It basically was not considered for anyone other than physicians who worked in Nazi Germany. This only changed much later. So why do we need to talk about this history? The history of Nazi Germany and the Holocaust is an extreme example of crimes against humanity, and health professionals, and that's important, had a major and often decisive role in formulating and supporting Nazi policies in theory and practice. And all histories of past and ongoing trauma are recognized as such by our Commission, as no hierarchy of suffering exists. Instead, and this is our main argument, the extreme and extensively documented example of the role of medicine in Nazism and the Holocaust may facilitate the recognition of patterns and common roots with other histories of medical abuse and oppression, and the recognition of the shared humanity of all sufferers. Recognizing this, in late 2020, Richard Horton, editor-in-chief, was approached by some of us with the idea of creating a series of articles on the historical evidence of this history. However, he gave us a much greater opportunity in creating the first Lancet Commission on the history of medicine. Lancet Commissions were introduced by him about 20 years ago, and there are about 70 of them, mostly on public health and political issues around the world. This is the very first one on the history of medicine, and he wanted it to focus on the time of Nazi Germany and the Holocaust. And the idea was to create, an inclusive international and interdisciplinary team to not only present up-to-date historical evidence on medicine's role in Nazism and the Holocaust to a wide audience, mostly to deconstruct myths and misunderstanding, but also to describe the relevance and the implications of this history for today and find ways to introduce this history into health curricula. The commission was announced in January 2021, and our report was published in March. That's okay. Take your time. The report was published in March last November, with official launches in Vienna and Berlin. Here we have the geographic distribution of our commission. We had 20 members, medical historians, bioethicists, educationalists, and clinicians, and we were supported by an international student advisory council. We strongly felt that we needed a wider geographical distribution, and we needed the young generation. We needed the students and the young professionals to help us with finding our arguments. We came from 14 nations, because we're still working, and we continue to have diverse politics and beliefs, and what's important, we come as the descendants of victims and perpetrators of these crimes. And we worked very hard for 3 years to find common ground in what we wanted to tell about this history and where we saw the implications. So after finding the historical evidence, we identified implications for this history for today. And you see us here at work in one of the few meetings where we could actually meet in person. This is in Jerusalem in April 2022. Most of our work happened during the pandemic with Zoom meetings. And we were brainstorming here around the globe and around the clock, thinking about what this history meant for medicine and the health professions today. And I should say that we truly came from different health professions too. So we came up with a lot of implications. This is a short list, actually, though the original list was about 120 items long. And I think just from this multitude, it becomes clear that the history of medicine, Nazism, and the Holocaust is relevant for every field of medicine and healthcare. It is relevant to today's perceptions of and debates in the health professions and the public. We were able to formulate 5 key implications that I will go into detail here now. First and foremost, the atrocities that health professionals committed during the Nazi regime and the Holocaust present to a large degree the outcome of corrupt moral agency in the face of potential dangers inherent to modern scientific medicine as it emerged in the 19th century. While medicine holds immense potentials to benefit humanity, it can also cause harm, and this is true at all times. However, it took the specific political conditions of Nazi Germany to transform these potential dangers into the particularly radical manifestations we document in this commission. The moral agency of health professionals became distorted through opportunities and temptations offered by the Nazi regime. Recognizing this potential within medicine and its practitioners through interactions with states, employers, or other authorities is important to understand one's own agency. In this context, preventive steps must be taken to counteract an ever-present risk of medical injustices or infringements of fundamental human rights. Our report discusses some of the specific risks linked to such factors as opportunities to abuse medical power, the tendency to objectify patients and research participants, dilemmas about split loyalties, and temptations to abandon basic values for ideological and opportunistic reasons. Secondly, the core values and ethics of healthcare are fragile and need to be protected. They require constant critical assessment and reinforcement. Health professionals in Nazism were not without ideas of their professional duties and medical ethics. They developed a specific form of ethics that put the health of the German people above all those considered to be outsiders, thus excluding vast numbers of individuals from their care. This exclusion followed eugenic, anti-Semitic, racist, and other discriminatory criteria and supported Nazi policies. Few health professionals did not question this distortion of their ethical duty towards the human beings in their care. This history provides a unique possibility to explore the aims and limits of professional ethics and how they change over time, dependent on cultural, social, economic, and political factors, particularly when put under pressure. Therefore, professional ethics in healthcare constantly need to be critically assessed and reaffirmed to ensure that they stay aligned with core values specific to medicine and to avoid becoming exclusionary and inhumane. Courage, resistance, and resilience are necessary to prevent and counteract potential abuses of trust, power, and authority in healthcare. Extreme forms of misconduct and abuse of power can be studied and analyzed in the well-documented context of medical involvement in Nazism and the Holocaust. At the same time, this history provides remarkable examples of physicians and other health professionals' resilience in the face of challenges and resistance to temptations, pressure, and coercion. These examples show that such courage, resistance, and resilience is not only necessary, but it is indeed possible. Health professional practice in the pursuit of scientific knowledge should occur within a framework that prioritizes individuals' human rights. This goes directly to research ethics. The physicians and medical scientists who performed coerced human experiments during the Nazi era often still followed the scientific rationale of knowledge gain. They believed that scientific validity was their only obligation concerning professional ethics. They did not consider the extreme cruelty of their methods and unbearable suffering of their victims, and certainly did not prioritize these individuals' human rights. However, protecting and respecting human rights are primary obligations for health professionals, including those working to enhance scientific knowledge in medicine. Only under conditions of informed consent is the pursuit of knowledge through research on humans justified, based on the respect for dignity, autonomy, and equality of every individual human being. And finally, and more relevant than ever, health professionals have particular responsibilities in fighting against anti-Semitism, racism, and other forms of discrimination. They have distinct credibility to challenge false scientific claims made by anti-Semites, racists, sexists, and other bigots, and they are in key positions to prevent, detect, document, or remedy human rights violations. Our remit was also to develop educational approaches that promote ethical conduct, moral development, and the formation of a professional identity based on compassion through education about medicine, Nazism, and the Holocaust. As a result, we propose a new educational paradigm, which we term history-informed professional identity formation. In 2014, medical historian David Jones and co-authors described the role of history in medical education as offering essential insights about the causes of disease, the nature of efficacy, the contingency of medical knowledge and practice, including ethical dilemmas, amid the social, economic, and political contexts of medicine. The authors argue that rather than fostering professionalism like the medical humanities, the role of history provides part of physicians' knowledge base to be effective diagnosticians and caregivers. They emphasize their argument by formulating insights from the history of medicine in terms of LCME-approved competencies. Our commission offers an expansion of the role of history in medical education, where professionalism defines the skills, values, and behaviors expected of a healthcare professional at any given time. Medical competencies refer to observable and accessible behaviors on different levels of competence. And professional identity formation, a presentation of self achieved in stages over time during which the characteristics, values, and norms of the medical profession are internalized, resulting in an individual thinking, acting, and feeling like a physician or other healthcare professional. This process of becoming a healthcare professional through learning and internalizing professional value and norms requires critical ethical vigilance about the need to both accept and adhere to professional norms. Importantly, professional identity has been described as developing in the context of a learning process that moves from the acquisition of knowledge on an informative level to socialization into the profession on a formative level, and ultimately leading to transformative learning and leadership skills and the formation of so-called enlightened change agents. In this conceptualization, Jones and co-authors' assertion that history of medicine contributes to the necessary knowledge base of a future physician refers to the informative level. The Lancet Commission on Medicine, Nazism, and the Holocaust, however, extends this claim to the role of history in medical education, contending that education centered on this history can go beyond informative learning, resulting in learning on the formational and transformational levels through prompting reflection on contemporary implications, for example. The Commission termed this new wider concept for the role of history in medical education, history-informed professional identity formation, which refers to all levels of learning. We're defining this as the shaping of professional identity, so learning about and reflecting on historical episodes in which medical values and priorities were challenged. And this learning can support the skill of pattern recognition, which promotes learning through self-reflection and priority setting and ethical decision-making, and it contributes to the prevention of ethical transgressions in medicine. Here are some of our recommendations. This history should be a mandatory part of health sciences curricula to allow for critical reflection on the connections between the historical and contemporary values and ethics of health professionals. History-informed professional identity formation should be adopted as a foundational approach in education. And medical institutions everywhere in the world should promote research on their own history, identify the victims in its history, and memorialize them as individuals. And finally, and most importantly, health professionals need to implement a set of core responsibilities regarding anti-Semitism, other forms of racism, human rights violations, crimes against humanity, war crimes, and genocide. And this is a slide that I like to use in anatomy education. We health professionals know that there is no factual basis for claims that human beings are fundamentally of different value. Rather, we know through our education and daily practice that we all share the same human body in all its variations, the same human spirit in all its variations, and the same human rights. And this is where you can find our report if you find this link, you put in Lancet and Nazism, Holocaust, and you get the full documentation and the appendix that goes with it. Thank you.
Thank you, Sabine. Thank you very much. Do we have any questions from the audience or online?
Just a comment, maybe. It's interesting that in Germany, 1931, there was a law which was the most advanced law, globally speaking, in terms of human subject protection from research. And that law wasn't even repealed during the course of the war. I mean, that was current. So my question or comment, it was never clear to me if that law wasn't applied because of the untermention, or the concept of those people with whom they practice research were less than human, or because another, that's one comment. And the other I would like to hear your reflection. It's about, you mentioned about the use of some of the knowledge acquired by research subsequently, or even Edward Penkoff and the anatomy book. So maybe those are two disconnected things that have to do with some, I would like to hear about your reflections about that.
Yeah, so the first one was, that's indeed the case that when the physicians especially that were involved with the fact finding for the Nuremberg trials were looking for examples of legislature, or at least guidelines on ethics in human research. The only ones they found came out of Prussia and later out of Weimar Germany. And the latest one was from 1931. There was no other one they could find anywhere in the world. It was the so-called Leitlinien on medical research. And it included consent at the time. That, and as you rightly say, those guidelines that had law-like character were never repealed. They were, in fact, used in the context of work with those people. This why I like to talk about an exclusionary ethics that that developed in Nazi Germany. They were applied to those who were considered to be part of the German Aryans, right? But all others who were excluded, who were sometimes referred to as what you call Untermenschen, inferior beings, right? For them, very often these, or in general, were not applied at all. Right, so they were outside the law essentially. It's what my colleague, the medical historian Volker calls deregulated spaces. And interestingly enough, these deregulated spaces even existed in universities as long as they apply to people who were not considered to be part of the German folk, right? But they were even more so found, of course, later in the concentration camps, right? These deregulated spaces. So basically we have here an exclusionary ethics that worked really well. As you know, there was also a lot of preventative medicine in cancer care coming out of Nazi Germany at the time. And that all was developed in the context of care for the German, the Aryan folk. But whoever was not considered to be part of that folk had no part of this kind of care, right? The second question is the knowledge gain, the data that came out of experiments or any type of even quote unquote routine work in medical science at the time. When we talk about medical experiments, only insofar as the data were published, where did they become part of the post-war knowledge base, and were often not even recognized as such data. This is different from those data that were collected by the US military forces, the physicians. They went directly after the liberation of Germany into the camps and collected all data sheets that they could find. Some of that was used specifically by the US afterwards. So the fact is, this type of data was used, and unpublished data as far as it was found. How far it was valid is a matter of discussions for the next ever since, right? So I don't want to even go into that. What I'm more concerned about is is the knowledge that was published on a routine basis that also went back to essentially exploitation of certain populations within Germany. So in our field in anatomy, the victims of executions after military and civilian trials, or of victims from euthanasia, their bodies used in the anatomical setting. These data are part of our knowledge base. We need to know that. And that brings us to the wider question: where does our knowledge generally come from? Where did it come from in the past, right? In every country where we had substantive knowledge gain, where did it come from? Whose bodies was this knowledge gained on, and under what conditions? So this is where we believe this history leads us right into the present. Also today, what's the basis for our knowledge gain, right? In how far have we considered the individual rights of the human being we're working with?
Hence the term history informed professional identity formation. This idea that history allows you to develop a better idea of where your
Where the
profession
information came from.
and how your profession developed and stuff.
Yes, and that goes directly also.
So yeah, you want to answer the question that was on the screen?
So maybe we should read it for everyone in
I
the
can.
US. Yeah, no, why don't you do this?
In the US, we've glossed over the history of how we treated African Americans, Chinese immigrants, and others. We taught about the inferiority of other ethnic groups. However, there seems to be an attempt to not face those truths under the guise of wokeism. Can you comment on this?
Yeah, well, we're in Florida, right? Coming from Boston, where we have all sorts of other heated discussions. So this is actually exactly where we hope that the Lancet Commission will have an impact, that every institution in every part of the world look at their own history, and look at their own systems, and actually do the research. You need the historical documentation, what happened. You need to do the detailed work on the individual victims, on the systems that went wrong, essentially, and you need to discuss it in your field. So yes, all of these histories that you mentioned there need to be further explored, and thankfully, I have learned in the last several years that our colleagues are working very hard, especially on the Black history of medical abuse. But a lot of this work has already been done, but as far as I'm told by my Black colleagues, they say they've also been silenced. Their research results have basically not been brought into the public. And this is also important. So I've had interesting discussions with Michael Blakey, a bioanthropologist, who's worked on the African burial ground project in New York, who actually had wonderful ideas of what to do with human remains of the enslaved and non-enslaved people who were buried there, which actually are reflected in some work that we have done on human remains from the Holocaust era. And I was not aware 30 years later of the work of Michael Blakey. And he said, well, his work has never been received in the public. It's documented, he wrote scholarly papers, but none of us have read them. So I think this is where we all can only learn and do better, go forward, do the work and do better.
Other questions?
Going back to the law from 1931 that you mentioned, that law then does not mention race at all. Is that correct?
No, that was in the Weimar Republic, which was an unstable but democratic system. Yeah.
So I'll ask a question. What do you think is the most pressing issue today that the Lancet Commission's report can emphasize or illuminate?
We want this history to be heard and taught. This needs to be part of all healthcare curricula. Richard Horton, the editor-in-chief of the Lancet, only learned about it about 5 years ago, and which is when he was greatly embarrassed. And I think that he's not alone. Many of us are not alone. I certainly only started working on the history of anatomy in Nazi Germany 20 years ago. late in my life, early in my anatomy career, when a colleague asked me about the Perkoff Atlas, and I was greatly embarrassed that I never heard about it. So this was an Austrian anatomist who, during the Nazi regime, he had long worked on an atlas for which he needed lots of bodies, and under the Nazis, he had access to lots of bodies of executed victims of the Nazi regime. More than 1,300 had been assigned to Vienna anatomy. Among them were 7 Jewish bodies, but the rest were also political resistors and so on who had been executed. And these bodies became part of this anatomical atlas. And it became enormously popular after the war, especially also here in the United States. So that's definitely an example of knowledge that has been used and still actually is used. We have some newer surveys where we know that especially neurosurgeons and facial surgeons still use the atlas. So at a minimum, we need to know this, and we need to talk about the victims, and if we know the victims' names, we have to name the victims. Yeah.
And you knowledge, how many medical schools in the States actually have a curricula like that? Which are the challenges to implement? And the third part is why we didn't teach that before.
Yeah.
Could you repeat that question just so that?
So, yeah, so the first one was how many schools actually teach this? How could we increase the teaching of the subject? And the third, why haven't we done it before? The third is probably true for just about everything we're doing, right? Why hasn't it been done before? So the percentage in the United States, I don't have the exact percentage in mind. Shelley Rubenfeld out of Houston had done a survey a while ago, and it was a fraction, 20%, I think, who taught that history. How do we get it into curricula? So you're talking to anatomists. We can't even get anatomy into a curriculum. But I've learned from my medical historian colleagues that we can find spaces in the curriculum, lunch talks, right? If you can find somebody who brings a lunch. But I've also given lunch talk without lunch, and students came. These are elective, but not mandatory, right? So that's the problem. Getting anything mandatory into a United States medical curriculum is probably every one of us has tried it, and it's kind of a hopeless undertaking. So I start with the small stuff. This year, so you can partner with students. There are often student organizations who want to talk about this, and you have to pick your time. So currently trying to even talk about this topic at Harvard is really hard, but we've done it. Again, with the student coalition, all of this is possible. We have productive discussions. Students want to hear about this history. And it's not just as Jewish students. I also want to say that, right? So we have you will always find a group of students who want to learn more about history, who want to learn more about the meaning of history for today. I'm looking forward to days when political situation is less tough and we can have a more
Well, you are hopeful, my goodness.
I'm a grandma. I have to be hopeful.
Tom, I have a question.
Yep.
Sabine, thank you so very much for a wonderful presentation. The history of this and a lot of the scholarship is about physicians, but it seems to me that a lot of what you've been talking about might apply to scientists who are not physicians as well. I wonder if you have a few thoughts about that. There's no good reason I can think of to suggest that they shouldn't be learning exactly the same things.
Yeah, so physicians was basically a very large group of professionals, but we do have similar studies on biologists, on chemists, the biochemists. Within the health professions, we do not yet have enough studies on nurses and midwives, but these are coming too. But that's definitely, these are also definitely fields that are included in our thinking here. We just have more data, more historical data essentially on physicians at this point, which probably also talks about the power that they had in German society at the time, right? They had a lot of agency to do good and to do bad.
Well, I think Ken is also saying that your conclusions should also include scientists as well as physicians, right? should kind of be in a history-informed professional identity formation for science.
Absolutely, absolutely, yeah. And that's what, in our field, anatomy usually was a combination of the two, right? They were trained as MDs and PhDs and did a lot of scientific studies. And again, these data are the ones that are in our books. We just need to know that this is the origin of these data.
Can I refer back to your point? I think there's an underground movement to get a lot of this into the curriculum. It's not being officially in the curriculum, but many of my anatomy colleagues, many other people are trying to bring this in, as Sabine said, kind of through lunch hours or as topical examples when we're preaching. I teach about what were called the Clara cells, but we now call them bronchial exocrine cells. And I say that they were named von Clara cells because this von Clara found them in Austria on Holocaust victims. So I can inculcate that into the lecture as I'm doing it, but it's not part of the official curriculum. They're not being tested over it. They're not getting any in that regard. So we're kind of doing it below ground to try to infuse that. But it would be really nice if it became part of the official curriculum.
I think I am the vice chair of the IRB at Baptist, and I said that clearly, and I had a session to my committee because we can do research, we don't know what happened, and sometimes we need to re-uncover what was uncovered.
Correct.
Yeah. And ideally, we would like to see this as part of a bioethics curriculum, but also in the individual medical disciplines, because truly there was no discipline that did not have examples of unethical conduct at the time. So we do it for anatomy, colleagues do it for pediatrics, for psychiatry was strongly involved, right? So again, there is no field of medicine that was not touched by this history.
One comment. You said, and I think this is very important. More or less, I'm following what Dr. Goodman mentioned. Something for those who are teaching research ethics is not well mentioned in all the talk, except when we are speaking in specific talks about the Holocaust. There is also always a mention of Nuremberg and that the crimes that were perpetrated in prisoners, not only by physicians, but also by all the structure, the pharmaceutical industry, IG Pharma, were made by crazy people or people which were monsters. And one thing I always try to emphasize, and I'm glad that you mentioned, those were normal people.
Yeah.
I mean, normal people, and maybe that's not the right way to mention, but those were people that were working in the concept of their society. And they were just doing, there was a wonderful book, right? Robert J. Lifton, the healing and killing balance that they have. So I think this is very important to show that those people were part of the society and were doing what society was expecting from them. And they didn't have any remorse for that.
Yeah, so the idea of Nazi monsters is exactly one of those myths that we wanted to deconstruct with our documentation in the report.
So they were just being anti-woke. But a question that goes to some of the thread that Tom began. The thread that Tom began. Suppose I'm a cell biologist or a geneticist or a physiologist, and I say, look, I'm never going to see a human being as such. I'm going to have a tube of blood, or I'm going to have some cells here somewhere. Why is this important to me? That sort of thing. And I think Tom began to answer that. I think you did as well, Sabine. I think that there's a real opportunity here to suggest that those ordinary people that Sergio is talking about are the ones who do science. They're the ones who did science in the 1930s and 40s in Germany. They're the ones who do science today in Germany, France, England, the United States, Japan, China, and so forth. And that I thought that the idea, what Thomas says was sort of clandestine, should be made explicit, that if you're a scientist, you have these social responsibilities.
And a physician, right? Scientists.
In addition to physicians, obviously. Yeah.
And we can expand that out to all professionals, right? If you're the head of a pharmaceutical company or you're the head of a manufacturing company, that should all be involved, shouldn't it? Wouldn't that be nice if that was an undergraduate curriculum as opposed to a, only specialized in certain professions?
And in fact, I think I saw earlier somebody from the Department of Religious Studies. I think I saw Professor Newell there. We do, I mean, so there are courses in religious studies, there are courses in philosophy, there are other courses across the University of Miami where I reckon that some of these issues are raised. It's a teaching moment, an unhappy one, but a teaching moment. You could argue that there are lawyers and sociologists and psychologists, psychiatrists, as you point out, that it's hard to say who ought not to learn about this important part of scientific history, which in many cases gets repeated, as we know. We're talking about Germany. We could also be talking about Japan, or as Dr. Gonzalez mentioned, the United States. The German eugenicists made great use of eugenics work from the United States. Is that not true?
Correct.
And we try to pick up from that so that basically we start with our history, not 1933, we start before, right? So what happened before, including in eugenics, because that's an important part of this history. I would also like to note that with this report, as long as it is, there's an additional long appendix with additional case studies and also medical educational tools for those of you who might have a chance to build a new curriculum, and also some example curricula that might be interesting. Also, I can always get you in contact with people on the commission if you need additional information.
Yeah, Sabine and I are always willing to help undermine curricula to get the proper things in there. Sorry.
Thank you. It's a very informative presentation.
Thank you.
Question I have is I'm listening to the discussion. If you look at the how medical knowledge, scientific knowledge has accumulated over the years, there are a lot of studies done in the past that would not pass the IRB review today, whether human subjects or animal subjects. So also, over the years, when it comes to access to healthcare, the different groups had access and other groups did not have access. So my question is, based on the your investigation of his historical evidence of that period, 1933 to 1945, what was unique about what happened in Germany and occupied territories that did not happen elsewhere?
The sheer extent of cruelty and of lost human lives. And to a certain extent, at least before 39, the involvement of the health professions of setting the system up, the extent of the collaboration. At this point, we have no other documented genocide with documentation of such an extensive role of the health professionals. I have an inkling that there might be something, or I was told by colleagues from Africa that there might have been something on a different scale going on in Rwanda at the time, but we have no documentation of that. So this is, as we said, the most extensive, most extreme example, and as far as we know, the best documented example of health professionals committing ethical transgressions at the time. And then, of course, the Holocaust itself, just in its size and anti-Semitic intent from the beginning, right? The Nazi regime leveraging the existing anti-Semitism in Europe.
And not to be too trite, I always like to say the Germans are very efficient. They will take anything, any good idea and make it as good as possible. And they just took that really bad idea and made it as good as possible. And they were really good at documenting everything they did so that we get all that documentation from them.
And I always answer you, I don't believe in national stereotypes. I've seen some pretty strong administration stuff here in the United States trying to immigrate.
Yeah.
Immigrate.
Oh, yeah,
You should have
indeed.
Yeah.
I share your,
But
I
you
share
can
your
see
pain.
that we like to exchange ideas. We do it on.
I didn't want to be trite about it, but at the same point, the Germans do a really good job of documentation.
Yeah, and they actually surprisingly did a much worse job in destroying the documentation after the war. So that we actually have much to work with, and not all archives have been discovered, and still we're finding things that are hiding in plain sight. We're just finding next week at the Toronto Anatomy meeting, my colleague Claudia Krebs will talk about a newly discovered anatomy crime essentially, so. It's still.
I would agree with
done.
Sabine that I think there are probably plenty of instances of this happening other places. We just don't have the documentation.
Yeah.
This is just one of those that is
And
so
not-
well documented.
No appetite, no political appetite for finding it, right?
Correct.
So we're trying to do this
Bury it.
currently in this state. Maybe you have to move.
Other questions? I'm going to ask you one that I think is interesting. So what do you think about euthanasia and how it applies to foreign findings from the Lancet Commission?
So you really need to look very closely. What the Nazis called euthanasia was not euthanasia. That was patient murder without consent, right? It was mass murder, right? So, but there are some interesting historical facts that are worthwhile looking at, and I can only recommend a paper on this by my now late colleague Gerrit Hohendorf, who has teased this out in much detail. What from this history is important to learn, for example, that there was no consent. This wasn't about the patient's care, it was about the patient murder, right? So there is much to learn looking at this history and then looking at where we actually intend when we use the word euthanasia nowadays, or use other words like
Assisted suicide.
Yes, exactly.
Medical
Well,
assistance
but medical
in
assisted death, right, exactly. So it's in the term alone. The concept of euthanasia, of course, is much older than the Nazis.
Anyway, it gives me some creep when I think that in some, not here in the States, because we don't have euthanasia here, but
No, but
in Canada, for example, or in Belgium, when even depression, if I'm not mistaken, could be a reason for asking to have medical assistance and die. It's a little bit complicated just to swallow and not to think. I don't want to say parallels because they're not, but also some kind of craziness in that regard.
It's important reflections, right? Where are the guardrails, right? So what do we have to think about? Why does this history come to mind when we talk about patients with certain conditions feeling like they can't live on any longer, right? So these are important questions. And I think we have to really keep on looking at the details of the history and the current cases, right?
It is worth mentioning that actually there are probably 15 or 20 states in the United States that do permit assistance in dying. The term euthanasia is not used much anymore in the clinical context. But there are several states. Oregon is one. There are actually quite a few, and in Canada is common. And so, Sergio, I'd ask you: I mean, the debates around that very, very often will talk to misuses of it, and what's happened in Belgium, for example, has been includes psychiatric patients, sometimes children. It's very controversial. It should be very controversial, but since they've been doing it since the last century in Oregon, they actually, some of them have documented that it does prevent a fair, I'm not advocating for it, I have grave misgivings about it, but in some states, they've documented that with proper guardrails, as you point out, that there's some people who believe it can be done without abuse. That's a topic of debate, but it is worth mentioning that it is increasingly widespread.
And again, our colleague David in Stanford, he has they allow euthanasia, they have a team of euthanasia. We just in the last conference, HPH last year, have a whole team, even though with pharmacies, with cocktails for euthanasia.
And then there's the slippery slope of the people who just provide more more opiates over time to patients that are somewhat terminal, right? This idea of, well, we'll ease them out of their suffering. And whether there's consent there or not and how that works, this is all that slippery slope. And I guess my question was, do you think the Lancet report can provide some insight into that? Or some
Yeah, we
guidance?
have a whole chapter on that. I'm not gonna read that.
There's homework
What
for you
we-
all.
So what we actually learned, which I find interesting too, because Ken, you just said the term euthanasia isn't used much anymore. We learned from our Spanish colleagues that in their culture, the term euthanasia is used all the time. So we had problems because we wanted to use it in the Nazi context. And then actually we struck it, usually in Germany, you write it then with quotation marks when you talk about Nazi practices. So we actually ended up striking it out completely. Because the Lancet actually didn't accept it with quotation marks. And then we said that's just too confusing, right? So we talk about the patient murders, which that's what it was.
Yeah.
Plain and simple.
Hi, Dr. Delasenda.
Hi, how are you? Thank you. I have a quick question more about the presentation. I'm being Jewish, that's what I'm saying. What I'm saying is there is a lot of anti-Jewish, not only anti-Semitism with the whole war and whatever. So the question is, how we can make this problem as is for all, meaning not only for Jews, because when you talk about the Nazism and all these experiments, some of the answers are, this is a Jewish problem, let them deal with the problem. This is not really going to affect us. And I'm saying that because that's part of, I work in the ICU and the pulmonary, so I get these comments, unfortunately, often lately. How you address that question?
Well, it really isn't just a Jewish problem, right? So for one thing, I'm not Jewish. And 75% of the commission weren't. But the victims also, the first set of victims were mostly non-Jewish Germans actually at the time of the forced sterilization and the euthanasia murders. But quite apart from that, this is a history that's of global relevance. As we see, it's a history about where medicine can go wrong. Medicine isn't Jewish or non-Jewish, medicine is medicine. This is where medical science, biomedical science can go wrong. So I would just go back to basics, right? And say this is a story about medicine in the Nazi period and the Holocaust. This is, the focus is on medicine, not on the Holocaust or even Nazi Germany. Does that answer your question at all?
Yes, thank you.
And I think it points to what we might say implicit biases in medicine, about how some people get treated better than others, about how there is this us and others kind of a phenomenon. And again, I would hope the report, is trying to emphasize that aspect of it as well.
Yeah.
If there are not any other questions, I would like to thank you all for your attention. I'd like to thank Sabine again for an excellent
Thank you
presentation.
for making this possible.
And Dr. Goodman and the rest of the staff for putting this all together. And Sabine is around for the rest of the day. So if any of you would like to speak with her, let me know. And we can always work by email, etc. We're very willing to collaborate and extend this underground infiltration of the curriculum as much as we can.
Yeah, thank you.
Exactly.
Thank you very much.
Thanks so much, Tom.